and welcome everybody to this week's Maternity and Midwifery Hour. My name's Sue Macdonald and I'm the curator for the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour, and it's my pleasure to be chairing this evening's session. And it's week 4 of the 12th series. We're in our 4th year. I'll say more about that in a minute. And I'm so delighted to be joined by 3 lovely people, Dr. Florence Wilcock, Deepa Santosh and Helen Green. And they should all appear magically on the screen any minute, because I'm going to have to put them all on the spot to ask them to share a moment of the week. And there they are. Glamour personified. There we are. Well, could I start with Deepa with a nice moment of the week to share?
Hello.
Hi.
Well, I came off being a supernumerary newly qualified midwife this week, so I feel absolutely, my confidence level has really gone up. I feel really supported and feels good. So, and yeah, supported a few births of all different kinds.
Wow.
And I've gone from being really anxious, palpitations on my first shift to feeling absolutely great. So that's my moment of the week.
I think that's not just a moment of the week, that's probably a moment of the year and even of the career. That's fantastic, Deepa. And so good to hear that you're feeling confident and good, because you've obviously had a really good preceptorship program to look after you.
Absolutely, yes.
Fab. Thank you very much for sharing. How about Helen? Have you got a moment?
Yeah, so actually not on a dissimilar subject actually, but I've had another new cohort of new qualified midwives starting with me last week. So this week was their first week out on the shop floor, so it was nice to kind of see them getting through their first week and seeing them out on the shop floor.
And isn't it a bit like being a mother hen?
Yes, absolutely. Making sure they're nice and supported, and yeah.
Fabulous. Lovely, thank you, Helen. And finally, to Florence, have you got a lovely moment of the week to share?
So I'm going to go for this afternoon, actually. I did a postnatal debrief of a woman that had quite a complicated birth, but it was really nice because although we had to go through lots of things, she told me how she felt incredibly supported by both the maternity team and the intensive care team that she'd been looked after, and how she'd really felt that they'd individualised her care. And so what could have been a very difficult experience, actually, she felt psychologically very good about and very positive about. So I think that kind of ties in with what we're going to be talking about tonight. But it's really nice to have that feedback, because you don't often get that from women that have been really quite unwell, that actually those little things make a big difference.
And so reinforces you're getting it right.
Yeah.
Fabulous. That's that. What a lovely combination of moments to share. So thank you so much. I'm just going to do the little bit about where the maternity hour came from. A little bit of news, and then we'll move on to the main meat of the session. So just to remind people, some of you who are watching tonight might be new, and some of you are old friends, and I met lots of old friends yesterday at the Maternity Midwifery Festival, which was lovely. And thank you for all the comments and the feedback I got, which was really useful for future sessions. But for those of you who are new, might not realise where we came from. And that was actually the pandemic, the COVID pandemic in March 2020, which seems a lifetime away in some ways. But we started the maternity hour when we realised we couldn't have face-to-face sessions. There was no study days going on, no conferences or festivals. And there was an overwhelming need for midwives and people in maternity care to be able to get some information, especially at that time, around the actual COVID pandemic and the infection and what effect it had, but also about what was happening in other maternity services, how people were managing, how people were coping and kind of keeping themselves going. And it's kind of gone on from there. So that was a really good way of connecting midwives, of student midwives, anyone within the maternity services. We did have doctors as well, Florence, which was also lovely, because everybody brings a very unique twist to the story. So that's been really good. And we've carried on because people still seem to want us for this hour a week, which, as I said, I often say is the quickest hour in the week. Just to reiterate, it's all free. And it's all free to share. And please do share with your colleagues. If you enjoy this evening, which I'm sure you will, share with your colleagues. You'll get a recording of it. There's a podcast at 6 o'clock in the morning on Friday morning. And you do share, because we need to be able to share information and knowledge. And that helps us kind of think it through ourselves, helps us cement the new learning in our brains. And also, if you're doing a revalidation or something of that nature, it's very helpful, because then you can write it up for your portfolio and everything. I want to say a big thank you to all the midwives, all the student midwives, all our medics, everybody within the maternity service who support us to give a good service. It's a hard time. There's a lot of infections around. I know there's things like measles. I'm not sure how much is impacting maternity services, but it does seem we are under pressure. We're always under pressure, but people are carrying on and doing good care. And that's what's fantastic. So the other thing I always like to say is look after yourselves, just as you look after your women and babies and families. Really important. You're important. And keep yourselves well. Not too much chocolate. I said that yesterday as well. Okay, I'm just going to do a brief news because my brain is actually full of the festival from yesterday, which was very exciting. Lots and lots of brilliant speakers. We very busy. We went from, oh crikey, emotional safety and elevating maternal health. We had the lovely Chloe Tanuki from 5 Times More speaking, which was fabulous. They're very glamorous, but they're also, what they were saying was so important. So if you get a chance, have a look at those presentations online. Go to Matflix, you can access them, and it's all for free, remember. We had Elaine Hansack talking perinatal mental health. We had Jenny Cunningham highlighting the RCM research priorities work project, that she wants loads of midwives, loads of women and families, anyone engaged in maternity services and midwifery care to feed into, to find out what's important to be researched, and hopefully that might access some money into research that really matters, not just the sort of highfalutin stuff. Okay, there's also presentations on immunization, which was, you can imagine, was very, very packed, menopause, and the leadership with the NMC. So that was a little snippet of things there. We also had, and you can see this very fancy little thing I have behind here, talking about May's Midwifery, our 16th edition. We had a little launch party, and I have to say there's nothing that gets midwives and students going like a bit of cake. And we had a big cake, nothing left. Very impressive. Okay, other things that are going on in the world. Yesterday was the International Day of Zero Tolerance for Female Genital Mutilation. This week is National Apprentice Week. I couldn't find very much else going on, but I'm sure somebody will let me know, apart from next Tuesday being Pancake Day. Maybe, if you like pancakes, that's okay. And this month is the UK LGBT plus History Month. So things are going on there. Now, I'm galloping through because I'm so keen to get onto this week's session, because I know it's going to be really interesting and challenging to make us all think. We're going to look at improving and making things better in maternity care and service, looking kindness, and it's a kind of around the lithotomy challenge and towards kinder care. And I'm going to introduce all 3 speakers. So the main key speaker is going to be Florence, but Helen and Deepa are going to be providing some very practical pictures about what is being done. So just to illustrate what can be done in your unit. So I'm delighted to introduce Miss Florence Wilcock, a consultant obstetrician. She's got a special interest in improving women's experience of maternity care, and she works at Kingston Hospital NHS Foundation Trust. She's currently lead obstetrician for perinatal mental health also works with the birth options team, home birth team, and Emerald team to support their personalised interpartum care very active member of the Kingston Maternity Voices Partnership, and was responsible for the very innovative Whose Shoes co-production workshop, which many of you will know about. Many of you have participated in. It's really exciting and very innovative and engaging to look at your service with those viewpoints. And she co-founded, now it's hashtag MatExp with Jill Phillips, and that's a very much a grassroots movement of women, families and staff caring for and working together. So that's Florence. We also are delighted to have Deepa, newly qualified midwife, not so newly qualified because she's now fully precepted and sorted. She has a master's in midwifery. She's also a certified birth educator and a lactation specialist. She's worked in maternity care over the last 14 years in India and the UK. And her midwifery practice is strongly rooted in advocacy, both for women and for staff. And that was very much illustrated by the project she's described on one of the previous maternity midwifery hours about water and making sure that midwives were properly getting breaks, which included the water, really important. And she was selected for the Aspiring Improvers Programme of 2019 at UCL Partners, and has participated in a number of quality improvement initiatives, including the Upright Birth Project, which there's a lovely poster in the resources sheet, which is really good to look at. She's also an Iolanthe Midwifery Trust Award winner and particularly interested in optimising physiology and obstetric care. And finally, our lovely Helen Green is the Preceptorship lead at Kingston Hospital, has worked in the trust as a nurse since 2005, then trained as a midwife, and she's been in this particular role for the last 2 years. She's developed this preceptorship program and launched the Acorn Preceptorship program. I love the name. That's lovely. Her mantra is, that's even better, her mantra is grow, nurture and develop, which is at the heart of the Acorn program. So welcome, Florence, Helen and Deepa. The screen is now probably Florence's first, but I know that Deepa and Helen are going to participate.
Thank you. Thank you so much for that lovely introduction and for inviting me to speak. And yes, absolutely, I have brought a few friends with me because that's kind of the way I end up doing things. And I was asked to talk about the lithotomy challenge, which I've come on to. But the whole thing is trying to make you understand and realise that little things that cost no money, that you can integrate into your practice, make a big difference to the women we care for. Next slide, please. So why am I here? Well, Sue mentioned I've been doing 10 years. It seems incredible that a decade's passed. So I was on the London Maternity Clinical Network, and at that point I had what was called the patient experience subgroup, because we were talking about patients, and that evolved over the time I was there to become the Strategic Maternity Voice Partnership for London, with a co-chair, a lay co-chair. So you can see how things have developed over the years. But what we decided was we were going to run some workshops, these Whose Shoes workshops, which are centred around a board game using lived experience. We were going to have a very small pilot in maybe one trust or just one sector, and then see what happened. And as Sue mentioned, the whole thing kind of blew up, and we had people online, on Twitter, on Facebook, and workshops up and down the country, and everyone trying to improve maternity experience. Now, one of the outcomes of that initial set of pilots, which we did at 5 hospitals in London, was to draw together some of that lived experience into a little film. And I thought I would show that film today as a little bit of a kind of scene setter. Next slide, please.
Hello.
Hi, miss. You're needed for a major obstetric hemorrhage. Labour ward, room 32.
The sort of call that really gets your heart racing is they ring you and tell you there's a major obstetric hemorrhage and you haven't got any more information than that before you set off for the hospital.
Thursday night was a pretty tough time, actually. When your partner's in that pain, it was how can you be useful?
I was asked a few things repeatedly by the midwives because it was a new person, it was just like starting from scratch. There wasn't a sense of one-to-one care or anything like that.
Emily was asking, should I be worried about any of this? And the midwife said, if there's only myself in the room, then you've got absolutely nothing to worry about. If there are more people in the room, then there is something wrong. They are all trained, they're there to do a role, and they will fix whatever it is that's going wrong. At the end, we had 10, 11 people in the room, and I was in the corner holding my brand new baby child.
When my son was being born, his heart rate started to drop. So they sounded the alarm. The room filled up with people, but I had my eyes shut, and my husband just said to me, it's okay. And he had one hand, and then I had somebody else hold my other hand. And I don't know who that person was, but it was like they were there just to reassure me.
I was being monitored behind the curtain. I could hear midwives complaining about being tired. This made me feel like I was an inconvenience.
I've looked after a lady in labour who was hard of hearing, and she communicated by lip reading. I had to remember to keep looking up and using my thumbs and saying, yeah, the baby's coming. And like just facial expressions. And when she delivered the baby, I just looked up at her, and she was like crying, her partner was crying, and then I started crying. It was just lovely.
After my son was born, they transfer you to the postnatal ward. Everybody who saw me said, congratulations, well done. And it made me feel like a queen, because it was kind of, I'd done the best thing that my body could do.
I was encouraged to breastfeed, and for me, I did find it quite challenging. I was told a lot of different things, and I just wish the advice I'd been given by the midwives had been consistent.
I've done antenatal, I've done labour ward for years, and I've done the community, and just the whole lot of it. I love the job.
So I wanted to show that because some of the themes and things are the same, things that we should be thinking about today. The heart on the slide is made of comments from women on the MatX Facebook group about what they thought the key things were, the sort of essential words that would describe the right, good, positive maternity experience. And you can see in there, you know, dignity, choice, respect, kindness, all the things that we would hope that we would be giving every day. Next slide, please. So why am I still talking about this 10 years on? Well, sadly, it's still more than ever a problem. So Sue mentioned the pandemic. That was extremely challenging. And I'm sure that you, like me at Kingston, are experiencing incredible pressures in terms of midwifery staffing, let alone the maternity scandals and reports that are being sent our way constantly. There's also been this issue with lack of equality or equity across services for women that perhaps we're not listening to, respecting and responding to. And I've picked out Invisible, which is a fantastic report to go and browse through about Muslim women's experience of maternity care in the UK, and 5 times more, who did a full Black maternity experience survey, which is absolutely excellent. When I was doing my work in London, I was really shocked when I asked them to give me the CQC maternity stats by ethnicity, and they told me they couldn't because the response numbers were so low from ethnic minorities. And I was thinking, but this is London. I mean, we have a massively complex and diverse demographic. How can that be the case? Attitudes and listening to women come up again and again in national reports. Next slide, please. So what I wanted to aim to do is just share some very simple ideas and ways that you might employ in your day-to-day work. What would this be like if it was your sister, if it was you, if it was your family? Next slide, please. So I want to focus on teamwork and relationships. We all know that actually the best care for women is when we have everybody around the woman, that woman-centered care. So are we working effectively as a team? And I'm going to give you a little bit of my ideas and perspectives as an obstetrician. Next slide, please. Working with your obstetricians is really important. So we all know that continuity of care, relationship-based care is the best for women, provided by midwives. But some women need obstetric or anaesthetic input. And I've thought about this quite a lot. And I went back to the idea of, well, I'm a consultant obstetrician. What does consultant actually mean? And consulting doesn't mean that I have to see absolutely everybody. It means that I can give information or advice. So what I have done with the teams I work with, and pictured here is the perinatal mental health team, is to be a link consultant, make it clear that the midwives can email me if they're not sure, does this woman need a consultant appointment or not? What do I think? What is the benefit? You know, or is there a simple query that I can just answer either with a phone conversation with the woman or an email to the midwife, or a prescription I can do remotely that might save the woman coming up to an antenatal clinic appointment and the disruption that that's going to cause perhaps to her work or getting childcare, or at my hospital, parking. So building a relationship with your obstetricians antenatally is really crucial. Next slide, please. So then you need to use that relationship to support the woman's choices. It's not always clear what I'm expected to do. If a woman is so-called sent to me, that woman may feel, oh, now I'm in inverted commas high risk, I've got to see the consultant, that's a big scary thing. What language are you using? Are you explaining to the consultant what you're hoping, what question you want them to answer, or what the concern is that you have about this woman's care? And how are you explaining to the woman what the consultant can do? I know particularly my home birth team are very much, it's okay, I'm sending you to the consultant, but it's Florence, she's not scary, we work with her a lot, she'll think about you holistically. So if you build that relationship, then you can have that to and fro, and I can email the midwives back saying, I've seen this lady, this is what I think, I don't need to see her again, you can now action what I think needs to be done, or actually I am going to see her again at 34 weeks, but these are the things I think I'd like you to do in the meantime. And think about what the impact is, because as obstetricians, we're very good when you send us people of then clutching onto them and keeping hold of them and then doing this and that and the other just in case. And then that may end up impacting that woman's choice of place of birth. Suddenly she's become an obstetric case, and then maybe birth centre or home birth goes out the window. So think about, if I send her, what impact is that going to have on her other choices? And perhaps see if you can come and sit in your obstetric clinic and see what it's like, and build that relationship with your key obstetrician. Next slide, please. And also think about your relationship with women antenatally. There's quite a shift going on. So we used to keep all the knowledge to ourselves, and we were the experts and we told people what to do, a very sort of paternalistic, old-fashioned branch of medicine. Whereas we're really trying to work on informed consent. We need to appreciate that Dr. Google is there. Every woman, as soon as you find anything, will go and look it up on Google. Women always come to me. My scan said I had polyhydramnios. I've Googled it. I'm now worried. So let's acknowledge that actually the internet is there, and let's try and signpost women to good quality stuff on the internet, whether that's YouTube videos, Instagram, podcasts, baby apps. You know, we've got Best Beginnings and all sorts of other apps. So try and make sure that the information that women are accessing is the right quality, and share that information with them so they can go away and think about their choices and think about and understand what's happening to them, and then come back at the next appointment and have a good conversation, having had a bit of time to absorb what you're telling them. Next slide, please. This is me on the labour ward. I am literally running around dealing with everything, everybody, junior doctors, junior midwives. I'm dealing with theatre. I'm dealing with more than one woman at a time. So you need to help me get grounded and focus on the woman you're caring for when I'm called into that room. Next slide, please. As a midwife, you are that key person for that woman. I try and use a woman's name on the ward round. It helps cement them in my mind as a person, not room 26 or the lady with the breech or the lady with polyhydramnios. It's her name. So we will have a presentation of what's going on in the room, and then before I go in the room, I will say to the midwife, tell me her name again, and then I'll go in and go, hello, I don't know, Sue. Hello, Sue. My name's Florence. I'm the consultant here today. And then we're starting to build that relationship. When you hand over to the MDT, telling us what's really important, this woman may have planned a home birth and she's now on the labour ward. What are the key elements of her birth preferences that could be kept? What are the key things that will help her feel safe and secure and that her wishes are respected? And can you help explain why the doctor's coming into the room and what they might be thinking about? I've had women postnatally say to me, I had no idea that when I'd been pushing for an hour, a whole load of actions were about to happen and that the doctor was going to come in and expedite delivery. It was completely out of the blue. And better still, what role can you play in making that birth environment positive, and trying to avoid the need for us to come in the room at all? Next slide, please. With assisted vaginal birth, we need you, you've built that relationship with her, to help explain what we're doing. Give us a good S-bar handover, because we may be coming in and quickly having to get on with things. And then help us, particularly if she's got an epidural or spinal, by palpating contractions and supporting her and helping her through the birth of her baby. Sometimes I see midwives or student midwives get very task focused. You've got a lot of documentation to do. You've got to get the resuscitator ready. You've got to care for the woman. You've got to top up the epidural. You might have to give tranexamic acid. But actually what I need you to do is hold her attention and make her feel safe and supported while I'm talking to her about assisted vaginal birth. I know it's really challenging with staffing levels at the moment, but if you can have someone else there who can scribe or document, whether that's a student or whoever, just to help make sure that you stay with that woman. Next slide, please. So what is lithotomy challenge and why did I do it? Well, I had 2 emergency cesarean births. And when I'd started this work on on maternity experience, I thought about what I hadn't experienced. And I thought for NHS Change Day, I would sit in lithotomy. I thought I'd do it for about an hour. That might be enough time for the pushing phase and maybe suturing, and see what it felt like. And I can't tell you how much it surprised me, because even though I saw it every day and I kind of knew what I thought it would feel like, it actually felt very different. For a start, I couldn't get into the position myself. You need someone else to do it for you. It's actually impossible. And then you feel incredibly vulnerable. People talk across you. It's incredibly undignified, uncomfortable, and actually my legs felt really quite cold on the stirrups. And I can tell you, the thing that made the biggest difference to me was actually the then chair of our MVP, who's now midwife herself, the lovely Kate Greenstock, come in and literally come up to me, and she said, Florence, I was planning to come in and ask you difficult questions and make you feel uncomfortable, but when I came in, I saw how you looked, and she came up to me and said, would you like a foot massage? And I was like, absolutely yes, because everybody else was just kind of treating me like an object, and she treated me like a person. So I learned an incredible amount, and I've written a blog about it in the past, which I've sent the link for, but also more recently this week, I wrote a blog to go with this. So what happened as a result was lots of different people up and down the country started to follow suit and also think about lithotomy challenge. And what I wanted to do was invite a couple of them, so Deepa and Helen, to explain a bit about what they've done as a result, because I think it's something that a lot of us could think about doing. Because when you look at the CQC maternity survey, there are still women up and down the country giving birth in lithotomy, even when it's an unassisted vaginal birth, around 25%. So that's not great. We need to do something about it. Next slide, please. So Deepa, I'd love you to tell people a little bit about your upright birth project. And apologies, I didn't see your slide in time, so I made this one for you.
No, that's lovely. Thanks, Flo. So I did a QI project called Get It Right Upright. And the idea for the project was when, and I was not a midwife then, but I was an infant feeding lead, but I used to go on delivery suite, and I've seen that most women were giving birth either lithotomy or mostly, semi-recumbent. So I did a baseline audit to understand what the actual, numbers were. And to my surprise, like more than 30% of women giving birth in lithotomy and about 40% in, semi-recumbent, and, very, very limited percentage of women who were able to have their own upright position, like on a force or sideline and things like that. So the MVP was involved, and the hospital, also the head of midwifery, sponsored the project, saying that we need to change that. So we had a number of change ideas, like we first wanted to understand why this was happening, and women themselves were not aware, because the layout of the room with the bed in the center, and it was sort of, they just expected to be on the bed. Midwives themselves were like, some wanted to support it, but they didn't have the right equipment, or it could also mean like physical challenges for midwives. the medical team said, I mean, one registrar was really honest with me. She said, if you left me alone in a room with a woman on her fours, I wouldn't know how to facilitate that birth. So it was really, because it wasn't part of her training, she hadn't seen anything like that. So while we were discovering all of these things, I wanted something that would help maternity staff to feel inspired by it. I didn't want it to become another tedious thing that they had to do, because we're all busy anyway, and this was another additional thing. But I wanted something inspirational. That's when I stumbled upon your blog, and I saw you, you know, in that lithotomy challenge, and I thought, oh my God, this is such a brilliant way, because people, when we had a doctor do it actually, and a male obstetrician, and they actually wrote down what they felt. So they felt really exposed, they felt stressed. And in fact, they were wearing clothes. We just had a hospital gown on them. But imagine a woman who is, you know, just wearing the gown and totally exposed. And there were so many people in the room. We tried to enact a scenario. And it sort of dawned on them that, wow, how does it feel from the woman's perspective? And they felt exhausted, tired, confused. So then after feeling this kind of feelings, they decided to think about it and see how they can change it and what actions they can put forward in reducing the usage of lithotomy for things that we don't really need. Something like getting the woman ready for the doctor was also about putting her in lithotomy and waiting for the doctor to come in, and that was totally unnecessary. So we discovered a few things like that. And the lithotomy challenge was something fun to do as well. I mean, obviously it's not fun for the woman, but as a clinician to get into that role, it was something totally different that caught everyone's attention. So that's where we started, Flo, with the lithotomy challenge.
Thank you so much, Deepa. Next slide, please. So now I'd like to bring in Helen, because Helen is doing something interesting with lithotomy challenge at Kingston again. She's thought of a way of incorporating it into kind of normal day-to-day. So Helen, would you like to tell us a bit about that?
Oh, thank you, Flo. I remember very vividly having a conversation with Flo back in 2022. Actually, I'd read something, I think, about that week about the lithotomy challenge, and I think Flo might have overheard me in our handover room, and it inspired a very big conversation about it. Obviously, within my job role, I'm embedded within practice development, so I do training throughout the whole of maternity, but I oversee the Preceptorship programme. Now, within the ACORN programme, the start of of their induction is they have a full skills and drills induction week, and we'd actually just had our first cohort start, and at the end of the week, they have a suturing workshop where they're just taught everything about suturing and how we do things. And it actually dawned on me that actually I had quite a captive audience, and where I could actually embed this. And actually it seemed quite easy at the time, and a bit of a light bulb moment, and actually just integrate it. So essentially what we do is we have our suturing training, and then after that I make everybody come over to our labour ward, and then essentially we then have a hands-on view of what lithotomy is like. And what is very interesting is that even just by asking our staff members to take part in the lithotomy challenge, the vulnerability and the worriedness before they've even got to actually doing it, and having somebody like myself saying to them, you know, it's fine, is to try and get the perspective of the patient, and the majority of them are obviously willing. And it's not just about putting them into lithotomy. What we actually do is we take it in turns, and everybody's placed into the lithotomy, and we open up our suturing pack, and essentially the rest of everybody in the room continues as if we're suturing. And I obviously try and make things a little bit difficult. I start having just generalised conversation about dog walking and what the weather's like and all of those sorts of things. And then sitting and actually then pretending to suture the patient, kind of talking to them a little bit and trying to sort of emulate what we're doing when we're suturing, maybe slightly towards what we shouldn't be doing, to try and give them an overview of what might be happening. And once everybody's actually done that and taken part in it, we then have a little bit of a debrief, and I like to know exactly kind of how they're feeling. And a lot of them say, you know, that they're feeling very naked, they're exposed, vulnerable, that they're alone. There's a lot of noise, there's a lot of lights. And one of the biggest things that has come out as well is that they can't really see you. So when they're there and they're draped and you're sat down and you're kind of talking to them, they might be able to hear you. You're just a voice in the background. They can't actually see you. Then they may have somebody else in there, a student who's kind of talking to you, maybe handing you some of the equipment. And again, they may be sort of talking to the woman, but again, is it that directness with the woman? So what it does is it kind of gives them that actual view. You know, some people are obviously have had babies themselves, so they have actually been in lithotomy, so they understand what it feels like. But essentially, it's just trying to emulate what it feels like to be in the lithotomy challenge. Like I said, I've got a captive audience of my newly qualified midwives. So what I'm trying to do is I'm trying to teach from the ground upwards, so that when they're in the rooms, that they can then bring this this practice model and making sure that the patients feel nice and safe and as less vulnerable as possible, making sure they're covered, making sure they're being spoken to. But moving forward, myself and the perineal midwives, we've got some study days coming up. So we're actually going to start embedding this in those as well, so that actually we can then put this to the wider part of our maternity unit, so that hopefully we can actually create a kinder environment for our patients when they have to go through what is ultimately a vulnerable time for them.
Thank you so much, Helen. I really appreciate you coming on, because I just love the idea that it's getting integrated into, this is the way we do things around here, rather than it being a special, oh my goodness. And I completely agree with you. When you ask people to do it, everyone kind of shuffles around and is really embarrassed and doesn't want to, which tells you everything about why we shouldn't be doing it for women either.
Absolutely, especially when they're closed. They have, you know, they don't have all of those vulnerability aspects that the women actually do. So
yeah, thank you. Next slide, please. So I just want to talk briefly also about theatre. So the same with theatre applies as with an assisted vaginal birth. So if you're going to theatre maybe for a cesarean or a manual removal of placenta or third degree tear repair, again, staying with that woman, suddenly she's coming into a completely different clinical environment, lots and lots of people around her, like we saw in the film. And how can you keep some elements of her birth plan and what's important to her? Next slide, please. So another ripple from the lithotomy challenge was with Catherine Maybe at Derby, who unfortunately can't join us today. But she took a different perspective and did a theatre challenge. I'm hoping this video is going to work.
We've done it loose this time. Ready? 1, 2, 3. I think we've got to fall. Right away. Relax, girls. Just want to touch you a little bit. Okay.
So they did a whole theatre challenge. I love that film because we don't think about what the woman sees when we wheel her from her room through the corridors and into theatre, or even out of theatre to recovery, or from recovery to the postnatal ward. And that really brings it home to you how different the woman's perspective is from what we see. And they made a second film, which was some reflections of their thoughts of lying on the theatre table, which you can explore at Fab NHS website, which I've sent Sue some links for. But for me, one of the key things was someone saying how vulnerable they felt with their glasses off, which would be completely how I would feel. So little things like that we don't even consider are really big, important things for women. Next slide, please. So I'm hoping that this talk has given you some ideas, not only about the small things that you might do, but how you might actually go about doing some of them in your unit. And like Sue said, I'd love you to share this with colleagues, because getting a group of you together and just trying out some of these things, either, you know, on a shift if you have a quiet moment, or incorporating it into your training days, is great. Like I said, we're coming up to 10 years of MatX, and really it's for everybody, anyone that wants to improve maternity experience. Next slide, please. So think, what simple things or ideas could you take away from this hour? Could you run a lithotomy challenge or theatre challenge at your maternity unit? And if you go on the Fab NHS website, there's a specific MatX page, and there's lots and lots of different case studies and experiences from people, ideas about what things they've done in their unit, such as some of the ideas we've discussed today, but also other things like stop and celebrate, congratulating a woman when she's had a baby on her way off to postnatal, a bit like you saw in the film, or a graffiti board where people can write comments or announce the birth of their baby. All sorts of little things that make a big difference. Next slide, please. So I'm hoping that this has inspired you, and I'd love to hear your thoughts if you've got questions and things that you've been putting in the comments or sending to Sue. But that's sort of everything I wanted to bring to you today. So I hope you've enjoyed it, and I'd love to know if I've sparked any thoughts and ideas.
Gosh, I think you've sparked a lot. I'll say 4 of you, including Catherine, because I think it's fascinating, isn't it? Just the putting in the shoes bit, just because it sounds very obvious. You need to think about what it's like to be in that position, but when you see it or feel it, it becomes a much more tangible thing, doesn't it? So it's really fantastic.
Very different, yes.
And especially, I was thinking, I love the saying with women, and I like the way you really emphasize that, because we tend to get distracted by the filling in the forms or the computer or whatever. And what's important is that we are with the women. That's what our name is, isn't it?
Yeah.
So thank you so much to all 4, and in this context here, 3 of you. We've had comments, they're coming through slowly. If you have questions, do ask them, and nothing's too small or daft or anything, because there are no such things. We've got a comment from Katie Polkovic, and she says she loved it. Thank you, Flo. I never knew that person was Kate Greenstock that rubbed your feet. Got to go now, sadly. Love the Obs Pod. Whose shoes, MatX. It was Deepa and Flo that triggered my Ilanthea application for biomechanics training. Fabulous. So important. And that's, I think that also on the resources sheet, we've got the pod, the Obs Pod, your Obs Pod, where how do you fit all that in, Florence?
Well, I've gone to every other week because it got a bit tricky, but actually, that was a lockdown. I started in lockdown. I'd wanted to start a podcast, and I just thought I'd just go for it. And yeah, I enjoy it, actually. And I get good feedback that people find it helpful to either give to women to listen to a particular topic, or student midwives tell me they find it helpful. So yes, the Obs Pod, it's on the normal kind of podcast platforms, and I've got episodes on all sorts of random things.
Yeah, it's a really good resource, and so it is on the resources sheet. So have a look on that one. Okay, we've got another comment from Irene Casutana. Hi, Irene. And she says, hi, student midwife here. Yay. I'd like to learn how to perform VEs in other positions other than the classic semi-recumbent. For something so invasive, asking a woman to turn for the purpose of allowing me to perform a check seems unkind. Any views on that? It is quite interesting, isn't it? Because you said about the registrar who was a bit anxious about having to do something with a woman in hands and knees position, which I've had experience myself of someone saying, well, where's it all going to come out? And you do have to think.
That, you know, such an honest thing to say.
Yeah,
for the medical team and what their difficulties were. And, and it's so true that they haven't actually seen about in any other position.
No, but of course some midwives haven't, have they? And some students. Right. And I know students, there were a lot of students yesterday at the festival, they have their own concerns about if they don't get to see certain things in practice. So how would you, are there any advice on getting some experience of doing V's in different positions, or how could we move that into practice a little bit more?
I think that needs to become more normal. I mean, I would say, you know, I'll be honest, I struggle. I have done VEs in different positions, but I struggle to be, perhaps if I'm thinking about fetal position for an assisted birth, I really struggle. And it's almost like I have to imagine myself the other way round. But I have learned, with the help of the brilliant Sean and Emma from OptiBreach, I've learned to reimagine breech birth the other way round. So I don't see why, if we didn't reimagine VEs in different positions and give people experience and be braver at trying to do VEs in the position the woman's in. You know, because also there's that question of why are we doing the VEs and what information do we need? So for a VE where you absolutely need to know the position because you're taking a decision about assisted vaginal birth, okay, maybe I need lithotomy. But for have you gone from 2 centimeters to 6 or 7 or 8 or whatever? Do I need to change her position? Maybe I don't, you know.
About Helen or Deepa, any views? How could that come into practice a bit more?
I think some of it is just trying it as well, looking at what your patient is like at that time. What are their views? What would they like? I have performed VEs several times, sort of in left lateral. And again, it's then moving forward with your findings, then, isn't it? Was it, you know, how accurate do I think it was? But like Flo says, it depends on why you're doing it. If it's a decision-making VE, then obviously you need a lot more information than just, you know, how dilated they are. So, but yeah, I have done it. But again, you know, you just have to take in the whole picture. And like Flo said, you just got to be a bit braver.
And have a bit of paper to draw on what you're finding and then turn it around.
Yes.
Okay, I've got another comment from Bruno Marino, who says, really important to have this done with student midwives and newly qualified midwives. I think they are the whole system. And we're getting lots of comments. So thank you for everyone for sending the comments. Really good. We have Lisa JJ. Hi, Lisa. And she says, I'm a newly qualified midwife promoting physiological process, and it's a passion of mine. And on Tuesday, I won the Trailblazer Award for my props bag. Yes, you did. Well done, you. I'm hoping to champion a physiological processes day, and lithotomy challenge would be a great addition to your workshop. That's another one for your props bag. Yes, well done, Lisa. That was really good. I want to see this props bag, because this is a midwife who's developed a little props bag that goes into different rooms, labour rooms, that midwives can kind of help women try things out. I want to see that bag. Thank you for that, Lisa. And Sophie Coalfield says, how do we get obstetricians like you? Don't blush too much. I'm struggling to get OBS on board with all of this.
So you need to find a few or a person. So there's a spectrum. There's a very good organisation now called the British Intrapartum Care Society, which is midwives, obstetricians, and women. It's and it has a lot of young obstetricians who are much more women-centred and much more in this kind of vein. So depends a little bit where you are in the country. I have had people email me and then I've kind of said, oh yeah, I've got a friend up there or there, I can put you in touch, and then they might be able to help you a little bit more connect with like-minded people locally. So they are out there. There are people that are really keen, and particularly younger consultants are. So yeah, you've got to kind of find a champion and then build from there.
Okay.
I had to
Deepa,
do this. I had to find obstetricians who would be, interested in that. And by God, I went and started talking about yourself, Flo, as a consultant obstetrician in Kingston, and then I saw Professor Jim Thornton do the lithotomy challenge as well. So I actually used their names to say, come on, when they are able to do this, this is something that we can do as well. And then and that sort of sparked their interest to say, okay, maybe we should look into it and see what's happening. It also involved the Maternity Voices Partnership to say, actually, women want this. And then that also sort of brought the obstetricians in.
It definitely is a ripple effect, I think.
Yeah.
You just need that one or two people to kind of hone in it, and then everybody else will run. But then also making it normal as well. So normalising and saying, well, actually, this is what's going on in the rest of the country. Why are we not on the bandwagon? Come on, let's go.
Yeah, and I think sometimes you get the impression that some medics might not like it because it feels a bit fluffy. And yet, actually, what is being focused on is getting some of the skills that we should demonstrate and be very clear on. For example, assessment, and be able to feed back exactly what's happening, because you made that very clear, Flo, when you were talking about helping you as an obstetrician to know what's important, what the key things is. Because I think when you're not very experienced, you can float around and make it sound a bit like I'm just thinking of an old nurse's report years ago, sort of patients slept well, that sort of thing, rather than really honing on the physiological, what's happening physiologically, and what you've done and what the key science that we are good at. But maybe some people get a little bit flustered with some obstetricians. I'm not sure. I haven't had comments on that yet. Okay, next one we've got Claire Elliott. Hi Claire, says, let's not forget it's LGBT History Month. Focus on language adjustments to include all pronouns, etc. Women and birthing people. Everyone has a birthing experience. I don't know if anyone wants to comment on that. Helen, you're nodding away.
Yeah, I think it's we just need to be very aware of our climate and who the patients who we're sort of dealing with, and again normalising things. Yeah, absolutely.
It comes down to individualised bit, doesn't it, really? Okay, and lots of comments, not so many questions. I think people are just loving it, wrapped up in this. And so we've got Kate Oliver, hi Kate, who says, thank you. I'm gearing up to run a lithotomy challenge as part of my quality improvement project at my trust.
Yes.
Very much inspired by you, Florence, and hoping to reduce our rates of lithotomy position on labour ward. Fabulous. Well done, Kate. You need to keep in contact also with people.
Yeah, absolutely. I'm very happy to, signpost you to things or give you a bit of moral support if needed. It's great.
And this is the lovely thing with these initiatives. It's like the NHS FAB thing. There's so many people out there you can connect with so brilliantly. It's wonderful, wonderful thing to do. Okay, and Juliet, we've got onto another comment. Juliet in Essex. Hi, Juliet. She says, by lying down while those around you are upright in itself is so emotionally disempowering. By having an IV line in situ disempowers and increases vulnerability of clients. Having that experience personally made it real how some women feel during the personal journey. That's very true. Thank you, Juliet. And then we have another comment from Arwa Hadid. These, exactly, why are we doing them? Thinking about why and if they need to be done. It's not just about the dilatation. I think everyone would nod to that, Arwa, so thank you for that. Jenny Hall. Jenny Hall, thank you, Jenny, has got a question. What challenge is next, Flo? Just a little one. Add to the plate.
Can't say that at the end of the hour. I don't know. Has she got a suggestion?
Well, Jenny, have you got a suggestion? That'll take a while to come through, actually.
I don't know, because I've done lying on the operating table as an actual, having both my children, and that was what got me interested in maternity experience, because my children were both emergency cesareans, but were like one very bad experience and one very good experience, even though they were the same clinical outcome. So I know just how vulnerable and sort of disembodied I felt lying on the operating table. So yeah, I don't know. I will give it some thought.
And feedback. We'll have you back to share what's happening. Now, I think we've come to the end. We've come to the end. I did say it was the quickest hour in the whole week. So I'm going to say a huge thank you to Helen and to Deepa and to Florence or Flo. I've said Florence, yeah, not invited any otherwise. And also in the background, we have Angelo making sure everything's recorded so that it'll be accessible to everybody. It'll be accessible tomorrow. And then in that podcast at 6 o'clock in the morning on Friday. And Paul, who's been putting questions through to me, I did forget to say, that's why I keep looking away at the other screen, because that's how I get the messages through. Now, resources you should have all of those. If there are any further ones, we'll put them on the website so you can access it. Now, I'll see you next week. Now, next week, we're having a touch of complementary therapy. And we're going to be looking at the use of combs, yes, and reflexology during labour. And we've got the lovely Amanda Redford and Dr. Denise Tiran. So that'll be another interesting session. Always interesting. But this has got a lot. You've got a lot to think about. You might want to rerun this just to think about how you could do this in your own unit, or if you're a student midwife, maybe introducing it to your student group to think about putting yourself in someone else's shoes in a real way. Also, don't forget to book for the All Ireland event in April the 9th and the Leicester Maternity Midwifery Festival on 14th of May. And in the meantime, I'll say, take care of yourselves. Thank you very much for coming in. Thank you again to our lovely, lovely presenters and for all the thought and engagement for this. And we'll see you next week, this time next week. Take care.